Right into it, get started. Thank you everybody for coming today, and it's an honor to present to you guys, my peers, and I'm sure I've worked with several of you and been on rounds and have patients in common. This is a CME information. So today I wanted to talk about critical limb ischemia and talking about changing the paradigm from amputation to limb salvage. So this is an overview. We're going to go over the scope of the problem. Why is it important to us? Why are we talking about this today? Talking about the advancements in technologies and treatments, and really using this as a launch pad to talk to you guys about what we've done at Advocate Trinity Hospital, another Advocate facility in Southside Chicago, where we launched the first limb salvage program about 6 years ago, and how we're going to bring that to Advocate Christ Medical Center. So I'm going to start with a case, Mr. Squarepants, in honor of my kid's favorite TV show. So this was a patient that presented a couple of weeks ago at Trinity Hospital, 68-year-old male. He has a history of a left above the knee amputation. He had come into the emergency department, and usually if we have a patient at Trinity that comes into the emergency department, the limb salvage team is contacted immediately. However, this was a new emergency department physician, so he contacted one of the vascular surgeons at an outside institution because we don't have any in-house vascular surgeons. And so they looked at the CAT scan and they said, and looked at the pictures and they said, there's no limb salvage here. This needs to be above the knee amputation. Go ahead and transfer him to this hospital for above the knee amputation. The patient reviews, he was admitted overnight, and then we were consulted. Our limb salvage team was consulted the next morning, and he was also podiatry, who we work very closely with, was consulted. He was started on IV antibiotics. CT angiogram was performed, which showed total occlusion of the right lower extremity. So the CT angiogram, so what it showed is the left iliac artery was occluded. So why is this important? Because when we revascularize the right SFA, you have to access the left iliac artery. So in this situation, it makes it very challenging because you have no access on the left side, you have no access on the right side. So the questions that come about from this: can this be done? Should it be done? Because he has a left above the knee amputation, and how long can we save the limb? So let's just kind of backtrack a little bit. Let's kind of start from the beginning. PAD fast facts. Why is this important? Because PAD is the highest prevalence of any disease that we have in the United States, and it beats cancer as well as coronary artery disease, and this is growing, and we really don't treat this effectively and efficiently. And that's really why we're here today, to talk about that. You guys know the basic symptoms of claudication, pain with exertion, that tightness that they get when they walk. But what we're going to talk about today is the next level, critical limb ischemia, those patients that have ischemic rest pain, ulceration, and gangrene. So when we talk about critical limb ischemia, what we're talking about are those patients that have known peripheral arterial disease and either ischemic rest pain, some type of ischemic ulceration, or gangrene, threatened limb loss. Now, you have to be careful because this is different than acute limb ischemia. Usually chronic critical limb ischemia lasts over 2 weeks. Usually these patients come in few weeks, few months even of symptoms, and acute limb ischemia is a little bit different. We'll talk about it in a little bit, but it is important to know because those are the patients that come in with acute onset of pain in the leg, have mottled skin, and that's more of a medical and surgical emergency. So we all have classifications in all of our medical specialties, and same thing with vascular disease. So we have several different specialties, but it allows us to communicate with one another and talk about the severity of symptoms in our patients. So what we usually do is use the Rutherford classification, and it's pretty easy classification. And I'll turn your attention towards Rutherford class 4, 5, and 6. And that's what we usually think about when we're talking about critical limb ischemia. So Rutherford class 4 symptoms are rest pain. Rutherford class 5 symptoms, minor tissue loss, and Rutherford class 6, major tissue loss or any level of gangrene. So I get asked all the time, what is a good diagnostic test? Patient comes into the emergency department, what should I order? There's so many different options. What's the best option? So, obviously physical exam is important, are there any pulses, but it doesn't go very far. It doesn't tell us the level of the disease, extent of disease. Ankle brachial index or a Doppler, to me, is sort of like getting an EKG. It kind of tells you a little bit about what's going on, but doesn't really give you the extent of disease, the location of disease. It is 90%, 100%. Can I go antegrade? Can I go retrograde? So really, my favorite is arterial duplex. If you can get this done pretty efficiently, there's no radiation, there's no contrast, and it gives us an understanding of where's the blockage, where does it start, where does it end. You can do an MRA. It gives you an anatomical configuration. CT angiogram is also great, especially in these situations in the patient that I showed you, because you can look at the iliac arteries as well. And obviously angiography will give you both diagnostic and you can go straight to therapeutic. So when we look at the anatomy, you guys know pretty much simple anatomy. The iliac arteries, SFA, below the knee, there's three main vessels, the anterior peroneal and posterior tibial arteries. And these are what we call the angiosomes. So it's sort of like in a patient with coronary disease, when they have an inferior infarct, they have a RCA occlusion. Same thing here. When you look at an anterior tibial occlusion, that usually affects the dorsum of the foot. Posterior tibial affects the bottom or the plantar surface of the foot. And the peroneal artery is really the lifeline of the foot because it supplies collaterals to both the dorsalis pedis and the posterior tibial artery, but it also supplies the lateral portion of the foot. Now, why is endovascular intervention so complex? So one of the differences from coronary intervention is endovascular interventions, their peripheral vascular arteries, they have a lot of movement, a lot of torsion. They flex, they move, they bend. And so there's multiple different kinds of technologies that we have to use. In the coronary world, you know what? We balloon, we stent balloon, we stent, we use cobalt chromium or stainless steel stents. We do some atherectomy every once in a while. We've kind of perfected that technology. But you know, endovascular intervention is growing and continuing to expand because we're sort of still in those early phases like we were in coronary disease in the 80s. We're still trying to understand what's the best treatment option. We have an explosion of technologies out there that helps us treat these patients. So when we talk about the challenges in treatment of critical limb ischemia, we have to improve the treatment of CLI. We have to really focus on limb salvage instead of amputation. So what most people don't know, that even today, 30% of patients that are admitted to the hospital with critical limb ischemia undergo primary amputation as their first treatment of critical limb ischemia. 50 to 70% of those patients will never have an angiogram, despite the fact that we know that if you have an angiogram, you decrease the risk of amputation by 90%. And 60 to 70% have no attempt at revascularization. And there's significant disparities around the country. So when you look around the country, they practice endovascular and vascular disease in different ways. So if you look, this is from circulation. The lighter colors represent very low numbers of revascularization attempts, be it surgical or endovascular. And as you get to the darker numbers, the really dark red is 90%. So even if you look around the Chicagoland area, it's about 40 to 45% revascularization attempts for patients with critical limb ischemia. This study looked at amputation rates for those patients who had critical limb ischemia. We talked about Rutherford classification. Those patients just with rest pain, not even ulceration, their 4-year amputation rate, if doesn't go untreated, is 12%. So those patients that come in and you say, oh, they have rest pain, but now it's better, don't worry about treating them. Those patients still have 12% amputation rate at 4 years. But this is what's striking, is not just the mobility and the depression that comes with it, but really the mortality. And this is what's so important. With just rest pain, they have 37% mortality at 4 years. A minor ulceration, 50% mortality at 4 years, and a major gangrene, 63% mortality at 4 years. In this study, the authors stated in its conclusions that regardless of the recent advances in PAD treatment, current outcomes remain poor, especially in critical limb ischemia. Despite overwhelming evidence for the reduction of limb loss by revascularization, critical limb ischemia patients still receive significantly less angiograms and revascularization procedures. So how do we change this? How do we improve this? The first step is to change the culture. So you guys are in the hospital, you're in the front lines, you see this day in and day out, and this is what I hear around the country, around the world, is it's too costly to save a limb. The patient is too old. There's no bypass target, so really there's nothing to do but to do amputation. Amputation is considered a conservative therapy, whereas an intervention or surgery is considered invasive therapy. And you know what? They're eventually going to lose their leg anyway, so might as well cut it off. Do we really think that way in any other field? We really don't. If you have a morbidly obese patient that comes into the ER and he's having acute MI, do we say, you know what, he's going to die anyway because he's overweight and he smokes, and so don't worry about doing an intervention? No, you don't. You treat these patients. So in the battle against amputation, it's never the final answer. These patients have chronic pain. They have a higher rate of depression. They have decreased mobility. They have a higher rate of major complications. They have higher morbidity as well as higher mortality. So what do we talk about when we say major complications? We have 20 to 37% rate of major complications for amputation versus major complications, 16 to 17% for bypass surgery if you do limb salvage, 1 to 9% if you do endovascular therapy. So what do we talk about? Wound infection. If these wounds don't heal, then they have a higher level of amputation. Revision of amputation, 10 to 20% in BKA, and 8 to 12% in AKA. DVTs, cardiac complications, sepsis, bleeding, so forth and so on. And you guys have seen all of this. Not only that, but you see that there's a significant decrease in mobility. So if you perform limb salvage, 2/3 of these patients will be discharged home. However, if you perform an amputation, only 18 to 24% of these patients will be discharged home. With limb preservation, 20% are discharged to a nursing home, whereas 70% with an amputation will go on to a nursing home. And finally, with limb salvage, 80% at 2 years are living independently and 90%, at 2 years are mobile and 90% are living independently, whereas with amputation, 60 to 80% of these patients will never walk. So when you hear that myth of, you know what, go ahead and cut off the leg, start the rehab process, get them their prosthesis so they can start walking again, 60 to 80% will never walk again. So not only are we talking about mobility and complications, but also mortality. So perioperative mortality for a BKA is 5 to 10%. For an AKA, it's 15 to 20%, 20% mortality just for an AKA. And if you perform limb salvage, then the mortality is much lower. Multiple studies have confirmed that limb salvage is much more cost effective than amputations. And this is really denoted by the fact that these patients have higher in-hospital stays, they have rehab, they have prosthesis, all these things that go into it. And so again, this is a myth, the fact that it's much more expensive to perform endovascular procedures or bypass surgery rather than to perform an amputation. Now, people say, well, Jaafer, I guess you're not going to do an amputation in anyone. Well, that's not true. Those patients that are demented, that are immobile, that are non-ambulatory, that are institutionalized, you say, okay, these patients are not going to benefit from limb salvage. So how do we promote more aggressive treatment? We have to change the culture, as we talked about before. Physician education, because really a lot of this stuff we've learned on the job, endovascular interventions, newer techniques that have come along since really I was in training. We've had so much expansion, explosion of this. And you really have to have a team approach. Podiatry, wound care, nurses, primary care physicians, hospitalists, improve revascularization techniques, and patient education. And I think this is really important because, when you have a patient that has cancer or prostate cancer or breast cancer, they're going to go to the best place that they can find. And this is the paradigm that's changing. Patients have access to social media, they have access to the internet, and they go online and they will seek out places that focus on limb salvage. And so here's an example of a patient that came to us from Houston. He was being treated at Baylor Hospital, and this is his story.
name's Charles Pagelo. I'm a retired structural civil engineer. I've worked in high-rise office buildings, a lot in the offshore industry. Before I started all these problems, I had never heard of peripheral artery disease. I noticed that my left calf was feeling like it was cramping, and I didn't know why. It didn't make sense.
A lot of patients don't understand what they have. They dismiss their diagnosis as arthritis.
Well, as it progressed, he could no longer do the work on the rent houses. He did a lot of the work himself, you know, with the crawling up ladders, getting on the roof and things like that. He couldn't do that anymore.
Well, I got the first stint in, and it worked fine, but about a year and a half later, it blocked up again. So I went in, and my cardiovascular doctor cleaned that out, and then put another stent in, extended it, and that lasted for about another year and a half till it blocked up again. So they recommended I get a bypass, which is from the groin to the knee. After that, got decent flow, and but the problem is that thing blocked up after a year and a half. I woke up in the middle of the night, and apparently that's when the sudden blockage had occurred, and my foot just felt dead. And when I mean dead, I couldn't even move my toes.
Once it starts to involve the nerve function, which means numbness or inability to move your toes, that is almost at the end stage. So that is at the point where you could possibly lose your leg.
Well, his cardiovascular doctor here that put in all the stents, he said, Charles, I've done all I can for you. He said, I've used all the tools in my toolbox, and I don't know where else to tell you to go.
So that's when I decided to really start some very serious investigations to see what was out there.
So at that point, because from desperation, then he had looked over the internet and seen if there's any other options, and there's always another option. And then that's when he was able to find us in Chicago, and we were able to help him. One of the advantages of endovascular treatment is there's less morbidity, meaning that there's less hospitalization, the complications from the hospitalization, and there's less mortality. So the risk of dying is actually less as well, doing endovascular therapy over surgical therapy. So usually the way I do it is I see my patient as an outpatient in clinic, and then they come in for the procedure. Most of the time they go home the same day.
I couldn't believe it. I mean, we walked in the hospital, had the procedure, we walked out. It was just a miracle.
So there are countless stories out there like this of patients that felt desperation and felt that they had no other options. And unfortunately, they probably underwent amputation. But now patients are out there looking for new technologies, looking for centers of excellence for vascular disease. And in terms of new technologies, we have so many new technologies, as I mentioned, that the world of endovascular therapy has really exploded over the past decade. And really, it's about crossing these blockages minimally invasive and treating these blockages minimally invasively. So we'll go over a couple of these technologies and kind of how we do things, new technologies, new techniques. So here you can see an anterior tibial artery that's 100% occluded below the knee. So, you know, really traditionally you would look at this and you'd say below the knee amputation, there's no bypass targets, really nothing to do here. But here, this is one of the newer technologies that we have that allows us to actually look inside of the blood vessel as we're treating with OCT, which is a light, like a laser that allows you to look inside of the vessel, rotate around, efficiently remove plaque, and avoid damaging normal structures of the artery. Here you can see on the right-hand side rotation of that cutter. This is basically a cutter that spins at about 2,000 RPMs, shaves out the plaque, stores it in the nose cone, and the whole time you can see exactly what you're doing. This was one of the newest drug-eluting stents that we have on the market by Boston Scientific, a Luvia drug-eluting stent. And we were part of that clinical trial, and even with long lesions, up to 200 millimeters, showed an efficacy primary patency rate of 92%, which is better than bypass surgery, vein bypass surgery. So we have the technology, we have the capabilities, and these patients we can treat these patients efficiently. This is another technique that we use, a retrograde technique. This is sort of like the holy grail, probably one of the most challenging things that we do in the cath lab. Again, this is a patient that has a popliteal artery that's occluded. You can see that on the left. Into the anterior tibial artery, the peroneal artery, the posterior tibial artery is occluded. So you would feel this, this patient's foot. You would not feel any pulses here. You wouldn't get really much of a Doppler pulse. CT scan wouldn't really show much. And so we're kind of going blind here. So what we did here is we did retrograde access, where we access into the mid calf, into the peroneal artery. There you see the access, and then we use a needle through the compartments, and gained access to the artery and went retrograde instead of going antegrade, because we couldn't really get antegrade access. Then here you see, once you get retrograde, you're able to put a wire through the blockage. So the tenets of endovascular therapies, you got to cross it first, you got to put a wire in, and then you can treat. If you can't cross, you can't treat. So that's one of the most important things. So we were able to cross. We did atherectomy, balloon angioplasty, revascularization. This took about an hour and 15 minutes. Next patient, 79-year-old male, coronary artery disease, gangrene of multiple digits. Here you see his anterior tibial arteries occluded distally, and peroneal arteries patent, posterior tibial arteries occluded distally. Again, this is a patient that has no bypass targets. This would be a below the knee amputation if he didn't heal his foot. So in this situation, what we did is we went down the posterior tibial artery, and the posterior tibial artery at the level of the ankle branches into the medial plantar artery and the lateral plantar artery. And we'll get to that in a little bit. So we went into the posterior tibial artery, opened that up, tried to open up the anterior tibial artery. We couldn't do it. So in order to understand this technique, you have to really understand the plantar arch. So the plantar arch is basically where the dorsalis pedis artery comes down, and between the first and second digit, it dives down and connects to the lateral plantar artery, which arises from the posterior tibial artery. So if you understand this anatomy and you understand this connection, you can use this to your capabilities and to your advantage and go retrograde through that connection. Now, this connection is about 1.5 millimeters. So you have to be really careful when you're doing this, but this is how you do it. So you go retrograde. You can see here we're doing an angiogram through that arch, through the digits, and going through the plantar arch. And here you see the wire going retrograde through the arch, backwards up the foot. And now we have a catheter waiting for us. From the antegrade approach, we gain access, we internalize that wire, push the catheter down. Then we introduce a new wire, quickly push that down. And once you cross it, you do atherectomy, angioplasty, done, hour and a half, in and out of the cath lab, skin to skin. Patient did well. So let's come back to Mr. Squarepants. What do we do with him? So again, as you remember, a left above the knee amputation, came to the hospital with critical limb ischemia. You see pretty extensive gangrene there on the lateral surface of the foot. He was recommended above the knee amputation after CT angiogram was performed. We were consulted. And as you remember, he had a left iliac artery occlusion as well as right SFA occlusion. So we can't get access on his left side. So what we did is a new technique that we have is radial to peripheral. And this is the importance of companies expanding their technology, so it gives us more options to do things. So basically we gained access to his radial artery and then gained access to his pedal artery and then basically connected the dots. And so we were able to go all the way down radial artery through the plantar, through the aortic arch, down the right iliac artery, and then crossed the superficial femoral artery, popliteal artery, and into the anterior tibial artery. So this was about 400 to 500 millimeters chronic total occlusion. And so you see there the superficial femoral artery, the red dotted lines is where it should be. It's occluded, the popliteal artery is occluded, and then it reconstitutes at the anterior tibial artery. So we gain access to the dorsalis pedis artery in the foot and kind of connect our dots, as I mentioned before. And this is how we did it. So that catheter that you see there is from the radial artery. It's super long. The wires are about 200 millimeters. So this is all chronic total occlusion. And this is live. This wasn't sped up, but this is how fast we can get through these things. So then we get access retrograde. So we go up from backwards from a wire and catheter, pop through the chronic total occlusion backwards. And then now we put our wire in from up top that we had, find our channel. And now we've crossed the CTO. Took about 5 to 10 minutes to do that full process. And then we got back through into the true lumen. So once we get through, we know once we have a wire in, now we know we can treat. So we did orbital atherectomy, which is basically a diamond tip drill, and drilled out that cholesterol and the calcium at 120,000 RPMs. You drug-coated balloon technologies and stents to improve primary patency. The entire procedure took 2 hours. Here, you remember what it looked like before. This is after. The superficial femoral artery is open, popliteal artery is open, flow is all the way down to the dorsalis pedis artery. So to answer those questions, can it be done? Yes. Should it be done? Well, some people say, well, you know what? He's non-ambulatory. Guy has a left AKA. Why do you care if he saved that right leg? Actually, this is very important. That's what people don't recognize, because this is the only leg they have to survive. So this is the leg they have to stand up on, to cook on, to balance themselves on. If this leg is cut off, they're completely dependent on somebody else. So we've had patients that, for example, grandmothers that live with their grandchildren or their parents, and at least now they can transfer to their wheelchair. They can stand up, go to the bathroom, take a shower. At this point now, they're basically bedbound. You have to lift them up in your arms to transfer them from one place to another. So definitely it should be done. And how long can we save the limb? As long as it takes to stay mobile and to stay alive. So on the heels of this, we started the Advocate Trinity Hospital Limb Salvage Program about 6 years ago. And so this was a pilot program with goals to prevent amputation, to use an endovascular first approach with a multidisciplinary approach to treating limb salvage, following the outcomes, following the metrics, and to use it as a precedent for the larger Advocate Aurora Health limb salvage program. So why did I say, endovascular first approach? I don't want to get into it too much in this discussion because out of the scope of this, but what we know is bypass surgery versus endovascular therapy. Multiple studies have shown that they're about the same, if not a little bit better with endovascular, because you have decreased morbidity and mortality associated with that. But in that realm, we knew that endovascular for our setting was the best first approach. And so that's why we use that. And this is what came about from that. Another very short video.
We started about 5, 6 years ago when we saw that there was a disparate amount of patients in Southside Chicago that were still getting amputations, just like they are across the country. And we started this by initially changing the culture of our hospital. We did it initially by picking the right team. And it was like physicians like Dr. Gerson, Dr. Julie Taylor, Dr. Ali. We brought these guys in. We allowed them to see what we could do by saving limbs, and they understood. They were passionate about it as well. And because they saw these patients in their own clinic, they saw these patients that were getting amputations and how it affected them and how it affected their social life, their psychology. It's a big deal. And they had that passion from the beginning.
Because I'm a family physician, I see a lot of diabetics. And diabetes is probably the number one risk factor for peripheral vascular disease, one of the major risk factors. So we often check diabetics, we check their feet, their pulses, we send them to foot doctors.
We usually see referrals from family doctors and from the vascular doctors every day. There's a high incidence of vascular problems on the south side of Chicago, and once it's seen and once it's identified, then we use our limb salvage program with our members to be able to get the patients into one of the offices quickly.
The typical interaction is that the primary care doctor and podiatrist may identify a patient who's at risk for peripheral arterial disease. After that identification, those patients would typically end up in my office, or if they're inpatients, I end up seeing them in the hospital. Once I've confirmed that they are at-risk patients, then we'll probably pursue diagnostic testing of those patients.
So our podiatrists and our primary care physicians are really the gatekeepers as an outpatient. So they see these patients that come into the office that have maybe a blue toe or gangrenous changes. And instead of sending these patients directly for amputation, what we did is we worked with them to send these patients for limb salvage.
If there are any signs and symptoms, we get them to the vascular doctor quickly, immediately. We have a system where it's A, B, and C. So when I call a vascular doctor or the cardiologist, I say this is an A patient, which means he needs to see him within a week. A B patient is in a couple weeks, a C is the next appointment. And so we always kind of rank them in a triage manner to be able to get the most serious patients in as quick as possible.
We're diagnosing diabetes much earlier than we used to. We're diagnosing PAD much earlier than we used to. So all of these factors, I think, and then once we find a problem, we're referring them more quickly to get a definitive, treatment.
Since we've been doing limb salvage work, there definitely is an impact, and the impact is multifold. First of all, the patients who come in urgently or emergently, those patients still come in, and that's a consequence of a disease process that's been going on for them for decades already. The biggest impact we've seen has probably been in both the hospital and the clinic in terms of the number of patients we're getting amputations. I haven't sent a patient to get an amputation in a long time.
Well, there's definitely a multifactorial, multidisciplinary approach to this problem. And I think we are on the road to helping to limit the amputations that are going on in our community.
What we want to do is spread this program to many other institutions around the country, because it doesn't make sense if one hospital in Chicago is doing this. We want 100 hospitals across the nation doing this. And so using our example, understanding that this is possible and having the passion and the understanding and know-how to say, we can do this in our hospital, be it Chicago, be it Little Rock, Arkansas, be it Austin, Texas, wherever it is, use what we've learned and our knowledge and our understanding of helping these patients and bringing them to their institutions. I think that's the most beneficial thing that can happen.
So how do we do it? So patients, and this is sort of what we're using as a paradigm here at as we launch our limb salvage program in Christ as well. So those patients that had critical limb ischemia, they're identified initially in the emergency department, because those are usually what we see as the gatekeepers. And we wanted to make it as easy as possible, because ER docs, primary care docs, hospitals, you guys have a lot going on. So we want to make it simple, a quick order set. You open up the order set, limb salvage protocol, wound care is notified immediately. The on-call endovascular specialist, be it the vascular surgeon, interventional radiologist, interventional cardiologist that's on is notified. The patient is made NPO after midnight and prepared for revascularization the next day. Because what we saw most of the time, and you guys probably appreciate this as well, the patient gets admitted, then they get an ultrasound the next day. It doesn't get read till 2 days later. then he doesn't get seen till 5 days later, then he doesn't get a procedure till 7 days later, and so forth and so on. So we wanted to speed up the process. Then after revascularization, that's really when the hard work begins, because these patients are followed as an outpatient with wound care, with our podiatrist. We had dietitians that saw these patients. Smoking cessation was implemented, and we followed these patients closely. And we knew that in order for this to work, we needed to follow these patients, follow the metrics, and really demonstrate what we could do with an organized multidisciplinary limb salvage program. So as you remember, the national average for amputation for a critical limb ischemia was between 25 to 30%, as this is what we saw at Trinity Hospital, as this is a national average. When we use a multidisciplinary program at Advocate Trinity Hospital, we enrolled 126 patients with critical limb ischemia in 1 year, and our amputation rate was 1.58%. So we knew that we could significantly make a difference. We could change people's lives. We could decrease morbidity and mortality by implementing a organized limb salvage program. And we showed at 2 years a 66% reduction in major amputation, which is below the knee amputation and above the knee amputation. So on the heels of that, 6 years later, we're bringing this to Christ Medical Center with a multidisciplinary approach to treating critical limb ischemia due to peripheral arterial disease. And this is how it's going to happen. So those patients that are coming to the ER or are identified on the floor, basically, you'll identify with critical limb ischemia, which is rest pain, like we talked about, Rutherford class 4, minor lesions, which is Rutherford class 5, major lesions, Rutherford class 6. Then if there's high suspicion for acute limb ischemia, those patients fall out, because those patients are the ones that we talked about with mottled skin, symptoms within a couple of days, less than 2 weeks. And this is more of a threatened limb. So we want to make sure we consult our vascular surgery associates very quickly on those and get on that. However, those patients have gangrene, longer term symptoms. Then what you're going to do is you're going to get on Epic, and you'll get into the limb salvage protocol order sets. Now, given Epic and what it is in the launch, we still have a few weeks until this is final and implemented, but we will send out an email once that Epic order set is in place. So this order set will consult the appropriate physician that's on call that night. It'll ask you about an infectious disease consult if there's any pus or drainage, if we need podiatry, if there's a wound. Then what will happen is we'll prepare these patients for revascularization. It's all going to be within the order sets. Make the patient NPO after midnight. And then if the patient qualifies for endovascular therapy, they'll go to endovascular therapy. If surgical therapy, they'll go to surgical therapy based on this expertise and the decision of the endovascular or vascular physician that's on call that night. So you're going to see these algorithms, you'll see that algorithm, and you'll see this sheet printed around the hospital and in the emergency department, and we'll have some cards as well for your reference. Remember, acute limb ischemia, less than 2 weeks, ischemic rest pain, paddle and mottled skin, motor dysfunction. That's really, really important. So if they say, you know what, I can't feel my foot anymore, I can't move my foot anymore, that's more of a medical emergency. Chronic critical limb ischemia are those with ischemic rest pain, gangrene, ulceration. And as I mentioned before, these will be the orders. That's just a brief example, but there'll be more extensive order set in Epic. So we brought together the vascular surgeons, we brought together interventional cardiology teams that specialize in endovascular intervention to work together, as well as podiatry. And all of us will be sharing call and participating in this limb salvage program. And the goals will be to decrease major amputation, decrease length of stay, decrease mortality, and create a center of excellence for the treatment of critical limb ischemia. So in conclusion, hopefully I've demonstrated to you the impact and how important PAD, critical limb ischemia, and amputations are, and how much of a difference you can make in patients' lives by saving their limb. We need to overcome these myths about critical limb ischemia and amputation. We know we're under-treating these patients. We need to treat these patients more aggressively. And we're really excited for you guys to be part of this limb salvage program, because it is going to be a team approach, and we're going to rely on you guys to help us with this and to improve outcomes, save limbs, and save lives. Thank you very much. open to any questions. Yes.
Golzar, amazing work. Thanks for sharing all the
Thank you.
stories. Very, very inspiring. One of the challenges you have in a primary care physician is identifying these patients early enough. Like somebody I think cited in one of the videos where you guys at the beginning is mixing it up with arthritis. You have somebody who can't walk because they have COPD, suddenly complains about leg pain, and you ascribe it to arthritis. Do you have any pearls for either physical exam or listening to history from the patient to say, all right, well, this needs to make me think about critical ischemia or even pre-critical ischemia?
Sure.
How do we identify these patients?
Yeah, no, that's a really good question. It's really, identification is so important. So in terms of claudicants, we don't really know when claudication will turn into critical ischemia. So it's not like a coronary plaque where it's an unstable plaque that you say it's about to become, it's a stable plaque that is about to get unstable. So we are going to separate. So let's separate out claudication from critical ischemia. So claudication, so we see, I see these patients in the office all the time, and there's a lot of patients that are identified as claudication that is actually lumbar DJD, that's actually arthritis. So really the best way is the questions I ask them is I say, because you have all this, all these confusing contributions that can come into play. Say, if I ask you to walk on a flat surface, how far can you walk? And they say, oh, I can walk a mile. It's not claudication. Or they say, I can walk a block, and then what happens to you in a block? Well, I start getting back pain, or it shoots all the way down my leg. That's not claudication. Well, I start walking down a block, half a block, and then I get tightness in my muscle, in the calf when I walk, and I stop, and then it goes away, and then I do it again, then it happens again, then it goes away. And that's that's kind of the route that I take to identify a claudication. I think the most challenging, as you kind of mentioned, was claudication, but before it gets to gangrene. So critical ischemia, which is rest pain. So is it gout? Is it, is it arthritis? Is it there swelling? Is it due to lymphedema? There's so many different things that can come into play. And in those situations, give me a call, text me something, send me a picture, or any of your vascular physicians. I think the more we collaborate, and that's what this program is all about, is having that comfort level to pick up the phone and be like, hey, Jaafer, I got this patient. I don't know what to do. I'm not sure what this is. Do you think I need to get him in soon? Or do you think he can wait, just like Dr. Gersh said? Or, do I need to send him to the ER? Because a lot of times it takes me about 10, 15 minutes to elicit this out of them to really figure it out, because it's not easy. When they have gangrene, pretty darn easy. If they have an ulcer, pretty easy. But that critical limb ischemia right before they get to gangrene and ulcer is really, really challenging. And give us the opportunity to work with you guys to help figure that out. Yes. That's such a good question. So the question is when should you refer a patient? So should it be when they first start having claudication, or obviously with critical ischemia, definitely would refer. What I say, and what I usually I see these patients in the office, and even if they have claudication, it has to be lifestyle limiting symptoms. So I asked them, once I determine, do they have claudication or not? So we determine, it's not lumbar DJD, it's vascular, they have a SFA CTO. I say, does this affect your life? And if they're like, no, I'm pretty good. I can walk, I can go to the grocery store, I can do what I want to, I can climb stairs, and I'm fine. No reason to do anything. I walk away. I say, great, we'll put you on a statin, we'll put you on aspirin, we'll put you on a Plavix, we'll see you every 6 months, I'll look at your foot, and you guys can do that. If you're comfortable doing that, put them on a statin, just like you would, a cardiac patient or dyslipidemia patient or a diabetic patient, same risk factors, right? So once they have PAD, they pretty much have CAD. So you kind of know that. But so refer those patients when they have lifestyle limiting symptoms, when they're like, yeah, you know what, this is really affecting my life. I can't do those things that I used to be able to do. I can't mow the lawn. I'm a electrician. I can't do that anymore. And so those are the times that I say, you know, those are the times, go ahead and refer them over, and then we can help them. Awesome. Well, thank you very much, everyone. I'm happy to share my phone number. We can kind of get that out if you guys ever have any questions, concerns. Perfect serve me, text me. We're really looking forward to implementing this limb salvage program and really making Christ Hospital a center of excellence. And thank you for your attention today. Thank you.
That was amazing.
Thank you.
Yeah,
I
dude.
appreciate it. Thanks for the
Awesome
opportunity.
presentation. Yeah, of course.
Hey,
I'm Shivama, PGY student.
hey, how you doing?
Good. I actually, thank you for the lecture. It's
My
great.
pleasure.
I have a patient that Dr. Sahed is seeing. I
Mhm.
get